Here. We're fortunate to have three great speakers with us for a discussion on mental health and addictions. Heather Bullock is the co-lead of evidence synthesis at the McMaster Health Forum. She has an extensive background in healthcare policy and knowledge translation, holding progressive leadership positions. Most recently, she was Director of Knowledge Exchange at the Centre for Addictions and Mental Health, Canada's largest mental health and addictions teaching hospital. In this role, she developed and led an innovative knowledge translation initiative, the Evidence Exchange Network, which aims to make Ontario's mental health and addiction system more evidence-informed. Heather's research interests lie in how large jurisdictions implement evidence-informed policy directions in mental health systems. Gail Czukar is the CEO of Addictions and Mental Health Ontario, AMHO. AMHO's 200 local member organizations provide a wide range of services across Ontario for people with addictions in the Ontario. Gail is a member of the Ontario Mental Health and Addictions Leadership Advisory Council, providing advice to the government on implementation of the provincial mental health and addiction strategy. She chairs the Youth Addictions Working Group of the Council. She has also held leadership roles at the Centre of Addiction and Mental Health, where she has also served as a general counsel at Humber River Family Health Team, the Canadian Executive Council on Addictions, and in legal services in the Ontario Ministry of Health and Long-Term Care. She has also developed community-based programs in mental health and developmental disability and has advocated for rights of people with lived experience of disability as a legal clinic lawyer. Camille Quenneville is the CEO of the Canadian Mental Health Association, Ontario Division. The CMHA is one of the oldest voluntary organizations in the country and provides direct service to more than 100,000 people in more than 120 communities. Before joining CMHA Ontario, Camille served in senior leadership roles in public policy and communications in government and with Children's Mental Health Ontario and the Ontario Public School Boards Association. She also served as Chief of Staff to Ontario's first Minister of Children and Youth Services in Queen's Park. Most recently, the provincial government asked Camille to serve on the Ontario Mental Health and Addictions Leadership Advisory Council, where she provides advice on the government's mental health and addiction strategy. Welcome to all three. We'll start with an overview from Gail and Camille of current activities of the Mental Health and Addictions Leadership and Advisory Council, and an introduction to the basket of core services work. Heather will then share her top 10 insights into balancing research evidence, stakeholder input, and citizen insights in defining the publicly funded basket of core services for mental health and addictions. Gail and Camille will again share their thoughts, and then we'll open the webinar to questions and answers. But now, please welcome Gail and Camille.
Thank you, Stephen. Gail and I agreed that I would kick things off and give a little bit of an overview of the Mental Health and Addictions Leadership Advisory Council that was struck by the province about 18 months ago. There are 20 individuals from across Ontario that sit on the council. And as you might guess, we all have as you just learned from both Gail and my biography, we have 20 individuals with extensive background in mental health and addictions who make up the council. And in developing the council, we determined that every year we would have a public report and we would talk about the direction that we would advise the province to take with respect to mental health and addictions. And given that we meet relatively infrequently throughout the year, we struck some very significant working groups to really undertake much of the work that we would be looking at for the council. So let me just explain roughly what the overview is of the working groups at a higher level. So we have system alignment and capacity, and I'll come back to that one. That's the slide that you're looking at right now. We also have a funding reform work group, a youth addictions working group, which as mentioned, Gail chairs. We have a early intervention and prevention working group and a supportive housing working group. So it's useful for you to know that that's the broad structure of the council, but we're going to drill down a little bit and look at specifically the system alignment and capacity working group, because that is the basis under which the work that we're going to talk about today was done. So the core basket of mental health and addiction services is a very large and significant part of that working group. I will leave that piece there because both Gail and Heather will comment much more specifically about it. I will add that the data and performance measurement work that we've done thus far is also extremely important to the sector, as you might guess, but also to the progress that the council has made. We are very much in need of developing a very standardized and rigorous method of collecting data and moving forward on that. The data is critical so that we can implement and improve the manner in which we work on quality issues within our sector. So quality improvement is a very significant component of what we're doing, and Gail and I have undertaken quite an extensive journey on quality with our respective organizations in partnership with Health Quality Ontario over the last many months, and it will continue for another year or so on a journey to ensure that community-based mental health and addiction services have the same level and standard that we would all expect from the system. Finally, we talk about structural barriers. There are no doubt many structural barriers within the system, but the reality is, with respect to our work thus far, we really are looking at primary care and the relationship between mental health and addictions and primary care in community settings, and how individuals who need support for mental health and addictions are accessing it, whether it's through a primary care provider or how those who are in the primary care world manage and support people who come to them with mental health and addictions issues. So we are undertaking a lot of work in that area along with our colleagues within the local health integration networks, or the LINs, across the province. So if we go take a step back perhaps and look at the basket of core mental health and addiction services, I hope what I've described gives you a general outline of the issues we are contemplating within the within this working group in particular, and the council more generally. But perhaps Gail now could talk about what we're doing specifically on the basket of core services.
Okay, thanks, Camille. So on the basket of services, we thought that it would be a good idea to define the what of the system. So there are a couple of things about this that are important. One is we're looking to have a core set of services that the LINs and the ministry are required to provide and support. So the definition that we've adopted is that they must be accessible, available, and have dedicated funding support for core services. So this is to have some consistency and standards across the province with respect to what we're providing in the system. The other piece is that if we're going to measure performance, as Camille outlined, and quality, what of those are the things that we need to really focus on? So I'm not going to say too much about that because I think that's the meat of what we're going to get into. I'll just say that it was very important to into work, and we did a literature scan and all of those kinds of things, and started getting input from stakeholders, that we also were aware from the beginning that we needed to have a very strong evidence base for any set of services that we would put forward. I'm saying set of services. The language you have in the material is still basket of core services, but one of the very important pieces of feedback that we had through the process was, don't call it a basket. And we got that feedback from the reference panel of persons with lived experience and family caregivers. So we respect that, and we're not calling it a basket of core services anymore. We're calling it a set of services, or just core services. So the idea is to set some minimum expectations about the range of services that must be provided in every LIN. What will be provided at different levels has yet to be decided. So I don't think I'll go beyond that because I might steal some of Heather's thunder, but I'm sure we'll have more opportunity to talk about the dimensions of the core
Gail
services.
and Camille.
Just to say the McMaster Dialogue were very important in establishing the evidence base for
the
this
top 10 that we're about to reveal. So I wanted to just talk a little bit about how the McMaster Health Forum contributed to the process, so you can understand where the top 10 that I'm going to provide come from. We essentially did 4 things in support of this work that Gail and Camille have outlined. The first is we developed an evidence brief, which is a global and local search for research evidence at the systematic review level about the problem, and also to kind of tease out a possible comprehensive approach to addressing the problem that's couched in the literature. and any key implementation considerations that relate to that. And I will say that all of the materials that were generated by the McMaster Health Forum are now available on the website as well. So if you're interested in any of these, you're free to download them and use them. The second thing we did was to host a stakeholder dialogue, which is a one-day facilitated discussion, which sort of walks through the different elements of the problem, possible ways to address the problem, and to discuss implementation considerations. And I'll say that stakeholder dialogues generally try and invite and host key decision makers from different perspectives. So along with Gail and Camille, we're looking at a range of
this work
researchers, representatives of family groups, and people with lived experience. So people who are able to speak to the issue at a systems level and have a sense of what the current service system, how the current service system is structured. And so that was really the target of that work. The third thing we did, so that I would provide really specific expertise around decision makers and people who are really familiar with the system. We then discussed and decided to host a citizen panel, which was comprised of people who didn't come from a place of having lived experience of mental health and addictions per se. In fact, they were selected through the organization that we use, Asking Canadians, to help find us people to populate these panels purposely. For people who weren't necessarily that familiar with this sector. So these are people who are your kind of average Ontarians, representing a diverse age range, gender, other forms of diversity as much as possible. And again, it's a one-day activity. They're given a citizen brief, which mirrors the evidence brief, but is written in plain language. And generally information on the topics provided, what's known about the problem, and the approach to addressing the problems and barriers and facilitators to implementation. And I will say that the citizen panel is a unique way to get feedback from folks who haven't necessarily, again, had specific familiarity with the issue on what they think about this piece of work, as well as a way to elicit their values. So what is important to them as Ontarians as we go about making these kinds of decisions as a system. So those are the four things that we did at the McMaster Health Forum. And now I'll, without any further ado or drum roll, I will start with the top 10 insights that we had in balancing the research evidence, the stakeholder input, and the citizen insights into this piece of work, which we're not calling a basket of core services anymore, but a set of core services. So our first insight is, many of this will not be surprising to folks, but just to say that this is now kind of coming from a consensus place across the four different activities we engaged in. First, as Gail and Camille alluded to, right now in the system, Ontarians can't expect the same services for the same needs. And this was echoed both with the stakeholder dialogue as well as the citizen panel, with people having an understanding that depending on where you are in the province, you may not be able to access the same services. This also reflects the fact that the availability of the services differs depending on where you are in the province as well. So presumably, this is where the core basket work came from, is the recognition that Ontarians right now, if they move from one place to another, couldn't necessarily continue to receive the same types of services. The second insight is that a basket of core services is one approach to leveling the playing field. So, part of the reason, and there was a lot of discussion about whether this is actually a good approach or not in both of these different venues, but certainly people acknowledged that in order to address the fact that there is inconsistency in what's available, it's important to have a way of identifying what should be available regardless of where you live across the province. And this idea of a basket of core services or a set of core services is one approach to addressing that problem. So in the end, people recognize that this was part of a comprehensive approach to some of the current challenges we face in the system. The third insight is one way to approach the development of a core basket of services is by broad category of needs. So thinking about folks in the system, folks in Ontario, and what their current level of mental health and addiction or mental health and substance use concern needs might be. So this allows you to think about things in terms of what's mental health promoting, what's risk reduction services, how we're approaching people who have identified mild to moderate issues or severe and persistent issues. So that is one way that you can approach identifying the different categories of need, which we can use to inform the evidence brief and the citizen brief as well. And an alternative or similar kind of way is to think about complexity and, the complexity of someone's needs, from being, simple health promoting needs to very complex concerns that span multiple sectors and multiple issues, and thinking about addressing a core basket of services based on complexity. So those are the two ways we found that the core basket work could be identified in the literature. The fourth insight is that many services are supported by strong evidence of effects. We actually found a small number of services to be harmful, according to the literature, and many others have insufficient evidence. And this is particularly true in mental health and addictions. While there is quite a bit of evidence to support some of the services, when you start to try and tease out evidence for services for a particular issue or concern, or a particular population or group that's at risk, the evidence, at least at the systematic review level, is still emerging, which can make it difficult to base the decision completely on just the evidence base, because we need to acknowledge the fact that the evidence base is still emerging. While we do have good information about things that we expect in terms of services to be effective, we also need to acknowledge that not every type of service yet has that level of evidence to support it, but that doesn't necessarily mean that it's not effective or that it's not an important or valuable consideration to think about in terms of a service system and what's in it. So that is that's the fourth insight. Number 5. Factors other than evidence can inform the development of a core basket include, so here are the other things outside of the evidence that we can think about that might be important when we decide what's in this core service, this suite of core services. I think I might use suite of core services, although I'm sure there's problems with that too. The first is you can think about burden of disease or need, and I've sort of already discussed that a little bit. The second is the benefits and harms of the services. So to think about what bang for your buck do you get in terms of the benefit of providing a certain service. Alternatively, what are the harms of providing the services or not providing the services? And so those are another dimension that you can think about. Third, we need to consider the values and preferences about the outcomes achieved and the balance between the benefits and harms. So, these are tricky issues. Are we interested in serving the most number of people? Is our goal better access? Is our goal better outcomes? Is it a mix of those two things? What specific outcomes are we looking for? Are we looking for family members to feel like the services have met their family members' needs? Are we looking for services that the clients of those services are extremely satisfied with? Are we looking for this, marker of improvement in terms of symptoms? What is it that we care about when it comes to outcomes and the types of outcomes that could potentially be achieved with this suite of core services? And how many people can benefit, who might benefit, and who might be harmed by not investing in a particular service? Also, resource use can be considered beyond just the evidence. So, when we think about resource use, we can think about the budget impact of a service. So how costly is it to provide as a system? as well as the cost effectiveness. So maybe something's very costly to provide, but that's offset by the benefits and the outcomes that that service is able to achieve. So this is another consideration that needs to be tackled when making this decision about the core services. Next, impact on health equity. So if we decide as a system on a set of services that are available throughout the province, is that going to improve the equity of access? Is it going to be improving the equity of outcome across different population groups and those who have different needs and come from different places? So, by deciding one service that is very effective for one population group or one particular need, but not others, what is the impact on equity? And really considering health equity and health equity outcomes when it comes to what is this set of core services. Next, we can think about the acceptability to stakeholders. And when I think about this, I are maybe providing services. So what's acceptable for them to provide? What's acceptable for people to attend, and what sorts of services are people looking for? What does the government think on the political side, and what's acceptable? Are we taking a command and control approach to service delivery? Are we taking a consumer-driven approach to service delivery? Is it somewhere in between? How acceptable is the service to the system as a whole and the stakeholders in it? And finally, the feasibility of implementation. So we might have this great service that has tons of research evidence, is acceptable to stakeholders, we think is going to have a great impact on health equity, but man, we do not have the resources to implement it. That would be a lot of heavy lifting as a system, and unless we're really willing to invest in implementation, it might just not be feasible. And this, I think, sometimes we forget to think about, but is also very important when thinking about what we should have as a defined set of services for the system. So number 6, expanding the way some services are delivered may improve Ontarians' access to them. This note came out in both the stakeholder dialogue and the citizen panel. People were keen on us expanding our notion of services, how they're delivered, who they're delivered by. They were willing to think very creatively about that as a way to improve access to services, as a way to allow choice in terms of what, how services are delivered to meet people's needs who might be using them. And so there was a lot of discussion on both days around using online, telephone, group-based approaches. So not just the what service, but the how it's delivered is also a consideration that came out of these two dialogues and days. Number 7, a core basket of services should not be the only services available. System planning should continue to take into consideration the whole complement of services. This came out again both at the stakeholder dialogue and the citizen panel. While people understood that identifying a core set of services is an important move forward in the system, they also were concerned that we would have to limit what the core set of services would be. And that might mean that some people's needs might not be addressed by those core services, thus meaning we need to still have the ability to serve the person who has a complex mix of needs that's very specialized, but not necessarily open or available or accessible through this core set of services. In other words, people felt like this was an important start, but core should not mean only. So the core services should not be the only services available. We needed to think more comprehensively about a service package, and also to think about other ways to support services that aren't necessarily just through the government funding. So people thought very creatively about how we might capitalize on other funding sources to continue to deliver some of the services that exist in systems. Number 8. Some principles identified that should be considered when developing a core set of services include developing services that are reflective of the voices of those with lived experience and families, ensuring there are standards and accountability measures for services, supporting flexibility and choice in those services, and providing services that support people holistically and across the lifespan. These are some principles that came out from the stakeholder dialogue and were echoed in the citizen panel. We needed some ways to think about how we guide the selection, again, because the evidence base is still emerging in some places. And people really felt like these were some of the very important considerations that we needed to keep in mind as this process unfolds. Last two, number 9. Mechanisms for continuous innovation and assessment should be built into the process to ensure core services are updated as new evidence and models of care become available. Again, broadly reflected from the conversations of both places as well as the literature, you do not want a set of core services to become so static that while there might be evidence of new services and approaches emerging internationally in other systems or even in our own system, that there's no mechanism to incorporate those new services that might even be more effective than the ones we've already identified in future. So concerns from citizens and stakeholders reflected a need to ensure a process to revisit the set of core services so that we had an opportunity to reflect on, what new evidence has emerged around their effectiveness. Are there new services that previously did not have an evidence base that now do, that should be considered? So to make sure as a system we're proactively thinking about this core set of services, and it doesn't just remain the set that again get identified through this process for the next 10 or 15 years. Finally, and I think Gail and Camille alluded to this, the work on the core basket will be complemented by other work that is also being led by the Leadership Advisory Council. People were, through the stakeholder dialogue and the citizen panel, were really wanting to emphasize that this core basket, this piece of work, needed to just be part of a comprehensive approach to addressing the challenges we currently face in the mental health and addiction system in Ontario, and that it really needed to be complemented by other work that would ensure that we don't lose the ability to have a comprehensive system that has easy transitions across throughout and can be flexible according to needs. So those are the top 10 insights that we gleaned from our processes at the McMaster Health Forum that Gail and Camille have been involved in. And I think what we'd like now is just to hear a little bit of reflection from Gail and Camille, what you think about those top 10, whether you think we've missed the boat there. Is there anything else that came out for you really strongly with the process that you think are important notes or things you didn't expect?
Thanks, Heather. I think you have created a very thoughtful list of 10, as you say, insights. I would say they're both insights and principles from which the work has evolved. And both Gail and I are going to comment on this, and I'm going to start by being a little more high level and thinking more broadly about the work and again, building a bit of a context in. And what I would suggest by that is, as you might guess, and as Heather alluded to, the mental health and addiction system, for those of you that are perhaps participating in this webinar and are not all that familiar with it, is some describe it as a patchwork of services across the province. So as has been mentioned, when you are in one part of the province, you may get services that look quite different than if you were in another part of the province. So it's a very monumental task that we were presented with. And I'll just remind you that this was just one of the task groups within a larger committee. So it is a tremendous amount of work, and we were very fortunate to have the help of McMaster to do this work. But I would just offer that we really were put in a position of taking a very complex series of services and a list of programs, so to speak, and to try and get people to wrap their heads around what should absolutely be available and what is absolutely necessary for anybody who is struggling with a mental health issue or an addiction, regardless of where they live in their province, what they should expect from their healthcare and community-based mental health and addiction system. So
based on that, we really found that there were a lot of people who, generally speaking, felt that what we ended up with in terms of the list of services should be much broader than where we actually landed. And perhaps that's not surprising, but people want to avail themselves of whatever treatment or, excuse me. I apologize. I'm sure everybody's had their phone go off at an inopportune time. So we really had to begin to think through what was fair for the council to advise the province in terms of what we would recommend, what was fair for individuals to expect, and how could we capture that in a way that was also fair to the providers that are within the local health integration networks that we work with, what's fair to the people that we serve. Both Gail and I are member organizations, and how could we really ensure that we were capturing all of those different audiences, so to speak, or those different stakeholders, and being true to what we believe the system should be. And I would just suggest to you that we think we did a pretty good job. We probably have a bit of a biased opinion, but we think we landed in a place where there's a fairness factor, for lack of a better way to put it. We think we meet all of the requirements I just set out in terms of the people we're working with, the government we're advising, our colleagues on the council, and it is very much in keeping, as Gail alluded at the beginning, it is very much in keeping with the other components that are so important in terms of data collection and quality improvement. We didn't look at this particular piece of work in isolation, and I think Heather alluded to that. It really is part of a bigger mix and a much more thoughtful approach in terms of how all of these different pieces work together. So I will stop there, and I think Gail is going to speak more specifically in terms of the components that Heather spoke about.
So thank you, Heather and Camille. I guess just a few things, it's kind of been emphasized that there's a lack of consistency across the province. There's a lack of consistency from one kind of service to another. So let's just take an example. If we look at something like case management, which is a core mental health and addiction service in the community in particular, Lynn's asked us, what is case management? And if we're paying for a case management program, are we paying for the same thing in this Lynn or that Lynn or this community or that community or this organization or that organization? So that's one example. So if we're going to have some standards and consistency so that people who are providing funding, providing and planning the services know what they're supposed to do, and the public knows what to expect, then let's decide what are the core services, what are the key services that we're going to do that work with. So that was one of the purposes behind this. The point Heather made about knowing what not to do, where there's a lack of evidence, is really important. We're often challenged, particularly in the community system, on what the evidence base is for our services. So that was really the main motivation for going to the McMaster Health Forum. We knew that you would do a thorough job on scanning the evidence that there is for all of these services, and we gave them a very long list, albeit categorized into 8 sets of services, but it was cast, and they found the evidence that does exist there, and that was really good. So it's not news to us that there's a lack of evidence in certain areas, but it is great to have the evidence that was found and be able to say that it's supported. Beyond that, I guess Heather's identified a number of issues. The one thing I would comment on, which was number 3, the issue of how we the way to approach the development of a basket of services. It's often thought what we need to do is identify the severity of the issue. So if you're talking about sort of whether people have mild, moderate, or severe mental illness, then let's match that person to the service. But what came out in the course of the forum, and this would be an insight that we hadn't really thought about how to frame, is that complexity is more the issue. So many people with mental illness also have other health conditions and I guess life conditions. So poverty, housing, those kinds of things we know come into it in terms of influencing recovery. So we need to be able to accommodate the complexity, and complexity is different in that it requires integration and coordination among many sectors, not just mental health and addiction. So it isn't just let's assess your need and match you to the service. It's how do we make sure that we're going to respond to the range of needs that you have, and hopefully in the priority with which the person, the priority the person assigns to them. So what are your goals? And of course, this is the way most services work. What is the person's goal and how do we help you reach it? So those are just a couple of examples of things that came out in the course of our work. I would say that the citizen dialogue was particularly helpful to us because we have other mechanisms for getting input from persons with lived experience and their families, but hearing what ordinary citizens, such as they are called in this case, think about it and what the needs are from their perspective is really, really helpful. So those were very helpful.
Before we get to the questions, I just wanted to skip ahead just to a couple of things here quickly, and that is just to again to highlight some of the relevant forum resources. Shared the links before to our citizen panel as well as a stakeholder dialogue. We also have recently conducted a rapid synthesis on examining the impact and approaches to addressing the needs of people living with mental health issues. I'll share the link for that shortly. And a number of other resources that certainly can be found on the McMaster Health Forum site, and as well as a link to a public talk that we recently held on mental health with Michael Landsberg. In addition, just to highlight, we will have these webinars coming up over the next, or monthly webinars anyways, coming up over the next little while. So in November, we'll be having a discussion with the Sachs Institute on lessons learned from developing and implementing novel approaches to supporting evidence-informed health systems with a focus on their experience in Australia. And then in December, Dr. John Lavis will highlight, and then system works and how this can apply to other jurisdictions. So skipping back to the Q&A part now, I know one of the questions that we had from earlier related to the terms about the core basket of services and exactly what the issue was in terms of avoiding the word basket and whether it reinforced a negative idea.
You're right.
Yep.
That's what we heard. Is people were uncomfortable with that word.
Great.
I mean, I think that the association in the mental health realm is basket case, and people just said we don't want to hear it.
Angie Woodland asked, "What did you glean from feedback on value for many that was surprising?"
Or value for money or value for many
is what was the intended question.
The question of value for money in the mental health and addiction world is one that doesn't. I mean, the debate seems to be more around, or there is a debate. It's not the only one. The role of medication and the role of talk therapy and other kinds of support services. So. It isn't so much about money, it's that people obviously need all of those things, and how they get supported varies greatly. Mm-hmm. So it's more to the access question, that it's easier to get access to medication, for example, because our health system pays for it, because we generally operate on a medical model. It's easier to get that. Structured psychotherapies, for example, are not supported publicly at this point to the same degree. There are some programs that provide that, but it's not accessible generally to the public in the way that other kinds of services are. So it's something that often gets supported by employee benefit programs or whatever, and that's one of the reasons we're asking for that in advocacy around including this in the health accord, for example. So structured psychotherapies are important. And the other is supportive housing and other social determinants, so income advocacy, poverty. We know poverty and housing are two huge determinants of health when it comes to mental health and addictions that, again, are not as well supported as they need to be. We know we have huge wait lists for those kinds of, for housing. It's really important.
I would just add that, to Gail's point, generally speaking, we don't have a value for money conversation because our conversations are always about capacity and the lack thereof. So I don't think government, in fairness, they don't push back and say, are you doing enough with what we give you? I think they recognize, hence the Leadership Council, they recognize that much more needs to be done in our
we had a
sector.
question from Jody Younger about the citizen panel that we held. So maybe Heather, you can address this, but she asked that they can see there was a francophone and LGBTQ representative on the citizen panel, but they wondered about cultural diversity.
So we at the McMaster Health Forum work with this company called Asking Canadians. Has a big database of Canadians that they have some kind of basic demographics about, and they'll ask them to participate and explain what it is. And we can ask them to help us find people who represent different age ranges, different types of diversity. In this case, we said we don't want people who have specific lived experience. But two things I should note. So I would say in the room, yes, there was diversity, other types of diversity represented. We may not have had specific information given to us by Asking Canadians about that, but I facilitated the day. But I would want to say that, and I think somebody else I've been trying to look at the chat feed, might have mentioned this, there's no way that, 15 or 16 people reflect all of Ontario. And you can try for some diversity so that you can have a conversation where people are going to be inserting different perspectives. But certainly anything that we do at the forum can't be considered, reflective of the whole of Ontario, every stakeholder in Ontario, every citizen in Ontario. This is just a way of systematically getting a sense of the types of concerns that people might have, the types of options people think might be important to consider, the types of implementation considerations that they feel are important, what values they might think are important when making these decisions. So it's not representative of Ontarians, but what we do try and do is make it as diverse as possible given the number of people so that the conversation is really rich and reflects different perspectives. And it's not a quick process in that way. Some citizen panels, they'll hold more than one in different locations around the province, so it's a bit more of a comprehensive approach. So at least you're getting maybe some diversity according to where people are living in the province. There's also been some that have been held that take more of a pan-Canadian approach, but this particular one was one. We did our best using that company to get as much diversity in the room so that we could have a rich conversation with different perspectives. I have to say, just generally speaking, from that day, I was heartened that that people had such a deep understanding of the mental health and addictions issue generally, and also an understanding of the challenges in making these types of decisions. So, I didn't really know what to expect. Certainly, if you haven't yourself had experience or a loved one have direct experience with the system, how would you help think it through what a core basket or a set of services might look like? And the day reflected a really deep understanding of the issue from multiple perspectives and brought into focus a lot of considerations that didn't come out on the stakeholder day, which I think is what Gail and Camille are reflecting, that it was a nice complement to some of the other inputs they had to the process. This is one of the challenges, I think, with trying to get input generally speaking. We can't ask all 13 million people.
So we have quite a few other questions to get through, but the next one is from Judith, and she asked, what are the recommendations for measuring outcomes, performance, and how the core services succeed in recovery?
I'm going to deal with the measurement question. We haven't really gotten to that yet. The recommendations on data and performance measurement, we're just beginning that work, but
So the council, or pardon me, the data task group has put forward recommendations which the council has adopted in terms of how we proceed in data collection. Again, we have partners in this work, folks from the Center for Addiction and Mental Health and ISIS, the Institute for Clinical Evaluative Sciences, again, for those that aren't familiar with that organization. So, we feel strongly that that really is the foundation for much of this work. And so to Gail's point, we're hoping that we can get moving on that for sure before long.
Great. Judy commented that with regards to the third insight, she thinks that this is very important to highlight the fact that there is complexity and that collaboration with other sectors will be important. For example, brain injury, which has been found to be very prevalent among those receiving mental health and addiction services. I'm not sure if that's a question, but if there's anything you want to comment on there.
It's a fair comment.
Absolutely.
I think I would say, just from the stakeholder dialogue and the citizen panel, that came out, because when you start to look at what's effective in terms of supports and achieving outcomes, we're looking at often this, like, things that are more considered social determinants of health, like housing, like other types of supports, physical activity, nutrition. It's not just the traditional service sector. So that implies, and comes up in the discussion, part of the challenge here is making sure that our whole system is oriented and reflects, kind of help, is positioned in a way to help improve the needs of people who might be experiencing a mental health or substance use problem. And certainly I know the council, that seems to be resonating in quite a few of the things that I've participated in, that we need to make sure we're considering to keep in mind that cross-sectoral approach.
I could just offer a little bit of a historical note here. So, it was the ministry's policy in the 80s and 90s, when community mental health programs were first being developed, that there needed to be an emphasis on serving people with serious and persistent mental illness. There was a thought that it was only people who had been through hospital and were in the community that needed support. So they wanted to refocus to make sure that the resources were going to those with the greatest need, which is, it's laudable, it's important. It's not always the case that we allocate most of our resources to those with the greatest need. But how do you measure that? So serious and persistent mental illness was kind of the label that was given to that. What's happened, because of the way the system's developed, is that that emphasis means that there's a large group of people that aren't being served well in the community, especially. So that's where this whole discussion about mild, moderate, and severe and persistent comes up. It's kind of a historical artifact, but complexity, I think, is just a real sign that we're moving ahead, and we're kind of getting with the program that complexity is the order of the day in healthcare generally. So mental health and addiction has to be on that same track. If we're not addressing the range of people's needs, their mental health, their addiction problems are not going to improve.
Great. And Jody asked, what were some of the non-public funded options that were discussed as possible enhancers to the system?
We didn't discuss any non-publicly funded options.
The citizen panel said things like, we need to consider things like Bell Let's Talk as, another way to get some messages across. So we can think about private industry as playing a role in our system. The citizen panel folks also mentioned revenue from problem gambling that currently funds some of the problem gambling treatment system. So that's government, but it's a specific ring-fenced pot of money. They also talked about the role of workplaces. And so that, is not necessarily a source of a direct government service providing, but that workplaces were an important place where people, should receive supports and services, and that might not necessarily be part of what's considered this this core basket or set of services.
Yeah, I think it's important just to clarify. My comment is based on this leadership council is a creature of the province, and the understanding and expectation was that we are commenting on and recommending advice based on the publicly funded health system. And so at no time did we really undertake any options outside of that. But I completely agree with all that Heather has said.
I think people are just recognizing that not everything has to be put in this one particular piece of work, and that there are other resources that we have as a system that can be used to be invested in the issue in a broader way, and to make sure that we don't lose sight of that.
Yeah, my organization runs a social enterprise on workplace mental health, so there's no question. Yeah.
Great. There was a question about whether you could provide an update when the core set of services will be finalized, disseminated to stakeholders, and implemented by the ministry. Maybe that's a loaded question, but if you if you have a quick update on that.
To say that's loaded is kind of an understatement. Yes, it's Gail and I are just going to chuckle and say, stay tuned.
Well, we could say that the council's work is going until the end of next year. So we're just at the turnover point for year 2. So we're about to deliver our recommendations. Core services will be part of that for this year's report that Camille referred to. And next year, the core services work will continue to go into the standards and the gap analysis and those kinds of things. So stay tuned for next year's report, which will have more of the rollout.
So will there be a report this year from the council? Yeah. There was one last year that's available on the government website, just so people know, that identified the 5 investment areas. So yeah.
Right. Yeah.
Sorry.
Great.
So it's going to the ministry first, and then the ministry will have an opportunity to tell everyone what they're going to do with the recommendations the council.
Excellent. We've got about 3 or 4 minutes left here for the webinar, but so we'll just try and fire through a couple of these last questions. So one asked whether there was any consideration of the role of specialized services versus more generic services. This may be where some PWLE may have concerns about being left out. She just commented the eating disorders was potentially one specific.
Right. So one of our big challenges, which we haven't really talked about very much, was what to include and what not to include. So trying to be as inclusive as possible in terms of the 8 categories of services that we came up with to make sure we capture all of the important services. Eating disorders obviously is a key service that needs to be included there. So anytime there's a kind of categorization exercise, there's always a risk you're going to leave something out or it falls on the line between 2 categories. But definitely trying to, we did a lot of the consultation to ensure that we were including all of the key services that are currently being provided, and then, looking at how to make those consistent across the province.
Great. Now, Eileen had a question about the rapid synthesis that we conducted on the mental health and addictions. I'm going to suggest maybe, Eileen, if you can email mhf@mcmaster.ca, and then Heather can respond to your question via email, just as we're running out of time, because I know that was you had a particular question there. I mean, I think really this was a really great discussion. I don't know that we have time to address the last questions here, but I would just like to, again, thank Camille, Gail, and Heather very much for the time you've taken today. I think it was certainly a very important topic to cover and a very interesting discussion. Certainly, there's no, so it won't be the last discussion on this particular issue. I think there's always things changing, but we really appreciate your time today. And again, I'd just like to highlight that we have a couple more webinars scheduled for this year, and we'll certainly have some next year as well. But for anybody that would like, just check out the McMaster Health Forum site for more information about those upcoming webinars, and we'll have the links to register once we confirm the dates for those.